All right. So as everyone is joining, welcome everyone to another subspecialty VMR. These Mondays are very unique and special to me because we get to really dive into a subspecialty within medicine and learn more about it. So I'm really excited because today is a pulmonary and critical care medicine subspecialty VMR. And we have two really wonderful guests who are joining us. So our specialist discussant is Dr. Anna Brady. Dr. Brady, she's a pulmonary and critical care medicine fellowship program director at Oregon Health and Science University. So Anna, Dr. Brady, we're really excited that you're here. And I was wondering, before we introduce the case presenter, if you could unmute and I'm curious just how you developed an interest in pulmonary critical care medicine, and also what do you like to do in Portland these days?
Well, thank you so much for having me. It's a pleasure to be here. Gosh, I think I have always been someone who really liked kind of the breadth and depth of internal medicine. And so I kind of went back and forth between a variety of subspecialties, but I really like pulmonary critical care because I feel like I get to still see kind of every part of internal medicine, both in the ICU and then there are so many conditions of different types that can affect the lung, and you have to think about anatomy, physiology, microbiology. It's really kind of a field where you see a lot and interact with a lot. So I love that. I'm always learning something.
Yeah, no, I love that. And outside of medicine, what are some of your hobbies that you like to do?
Well, I used to bike a lot, but I have a 16-month-old daughter, so I don't bike quite so much anymore. But I like there's a lot of beautiful parks here in Portland, so I like to get outside when I can.
Amazing. Well, between your busy job and your 16-month-old daughter, we are so happy and grateful you've taken the time to be here. So the case presenter today is Dr. Brian McGarry. So he is an internal medicine PGY3 at Oregon Health and Science University. So Brian, thank you for being here, and would love if you could unmute and share, you're not in fellowship yet, but if you have a particular interest, maybe in pulmonary critical care, and just tell us about your interests.
Yeah, thanks for having us and allowing us to present a case from OHSU. I think first and foremost, my interest started with internal medicine, just because, like Dr. Brady said, the breadth is really enjoyable. I think the opportunity to work in hospitals and clinics is both really rewarding. I'm particularly interested in pulmonary and critical care medicine. Similarly, the breadth of it, you kind of get to see a whole bunch of different parts of medicine that intersect together in the intensive care unit and also in the pulmonary clinic. So it's that kind of ability to take care of really sick patients, which I find really rewarding in the ICU, and then also to be able to take that and work with people in the clinic with chronic lung disease, I think is a really good balance of things to be able to do. And so I think that's really what is pulling me in that direction.
That's fantastic. And also we'd love to get to know you a little bit outside of medicine. What are some things you like to do in Portland?
I also love the parks. I have a dog that I love to take around. So a lot of my free time is spent hanging out with him, either going around trails or exploring dog parks. I really enjoy. I also like to cook and read. And so those are kind of the two main things that I do outside of work. Cooking is important for life. Got to feed yourself. And so it's nice that I also enjoy doing it. So
yeah, definitely. Those are great hobbies. Awesome. Well, I realized that I kind of jumped into your introductions and I didn't introduce myself, but my name is Madalena. I also go by Maddie, and of course I'll be facilitating today. And we have our incredible scribe and person doing teaching points. So Shema, do you want to unmute and introduce yourself?
Yeah, hello everyone. I'm Shema and I'm a medical student. I'm now in my 5th year. I had to think, yes, in my 5th year in Germany. And outside of medicine, I enjoy coffee. I know it's not a hobby, but I say it's a hobby, and I found a new passion for matcha latte. That's all.
Ooh. I think coffee's a hobby for sure. Awesome. And Deborah, do you want to introduce yourself? I know you're doing Teaching Points today.
Hi everyone, I'm Deborah. I'm a medical student. I live in Argentina now. And outside of medicine, I don't like cook as Dr. Ryan likes to cook. I hate cooking, I'm terrible. So I think going for restaurants and other food, it's a thing that I like to do, but cooking, I think it's not for me. I appreciate everyone that can do it.
Amazing. All right. Well, without further ado, let's dive into the case. So Shema, you can go ahead and share your screen. Perfect. And then Brian, whenever you're ready, you can go for it. Oh, Brian, I think you're muted. I see your mouth moving.
There we go. I was muted.
There we go.
So this is a case from Oregon Health and Science University in Portland, Oregon. So this is a patient coming into an intensive care environment with the chief complaint of shortness of breath. So some of the information about this case was changed a little bit just to anonymize the patient, but this is a woman in her 60s who had first noticed shortness of breath that started about 2 to 3 months before coming in today. Her shortness of breath is worse with exertion, and she notices that over the past week it has gotten progressively worse to the point that she's using her inhaler, an albuterol inhaler as needed, but it doesn't really seem like that's helping. She can't really find anything that helps the shortness of breath get better. She also takes what she describes as a water pill that she's previously been prescribed for some swelling in her legs, but hasn't been taking it. She doesn't have any shortness of breath with lying flat. She's not waking up and feeling short of breath or gasping for air, so no paroxysmal nocturnal dyspnea. She's not having any chest pain, doesn't have any fevers or chills, no weight gain or loss that she's aware of, no coughing or wheezing. And she has pretty limited information that she can share with us. She's rather confused. And so some more information obtained from both her roommate and her sister is that her roommate found her kind of acting strange, a little confused, slurring her speech, and was really concerned about her. So she called 911 and she was brought in to the hospital by an ambulance. Some additional information about her, what we could glean. She has a past medical history of hypertension. She also has COPD. She has a history of alcohol use disorder and a history of anxiety and with panic attacks. She is also smokes cigarettes and has a nicotine dependence, and she is actively smoking. Jumping maybe to the medication she's taking. She's taking irbesartan and amlodipine for high blood pressure. She is prescribed furosemide. For her chronic lung disease, she takes a fluticasone and salmeterol combination inhaler, as well as an umeclidinium inhaler. She also has albuterol for as needed use for shortness of breath. She takes buspirone and escitalopram for her anxiety, and she has a PRN or as needed alprazolam, also for anxiety. Her family history, the significant parts here are just mostly her mother was a chronic smoker and died from complications related to COPD. For her social history and health-related behaviors, she's a current smoker. She smoked about a pack a day for 45 years, although recently has increased up to 1 to maybe even 2 packs a day. She also drinks alcohol. Typically in the past has had about 2 beers on average daily, although more recently has been drinking up to 6 packs daily, or sorry, 6 beers, so a 6-pack daily. And no other recreational substances. Some of these changes, she says, are related to stress. She had been recently unemployed, laid off from her kind of service industry job in the setting of the COVID pandemic. And she has no known allergies to drugs.
All right, so this is a lot of really rich details here, Brian. Thank you for giving such a thorough history. Dr. Brady, would love to hear just your initial thoughts on how you're thinking about this patient.
Sure. Well, the first thing I would say is, I know this patient has a history of COPD. And so, kind of immediately your brain wants to latch on to like, okay, well, is this, related to COPD? Could this be a COPD exacerbation? And, maybe what's going on in the last week, we could think about that. It doesn't sound particularly typical for a COPD exacerbation, but it sounds like this patient has had kind of a subacute problem. And so in someone like this coming in, I try not to anchor, too quickly and look broadly, particularly because we know that in patients with COPD, comorbidities are actually a huge, going to play a huge role in their care. And so I would definitely keep a pretty broad differential this early. And so even kind of going back far enough to say, like, do we know that she has COPD? If I don't have a set of pulmonary function tests kind of with me, I'll always take that with a grain of salt. Is it really COPD? Because often patients who have a long smoking history will get short of breath and they'll be kind of given a presumed diagnosis of COPD without actually going through the spirometry to prove it. So presuming she has COPD, just because of the history, again, with kind of this backdrop of kind of a 2 to 3 month period of shortness of breath, again, I'm not totally convinced it's just a COPD exacerbation. So I definitely am worried about cardiac comorbidities with the lower extremity swelling. So I would think about comorbid, coronary artery disease, congestive heart failure, either right or left-sided. Think about arrhythmias. Patients with COPD can certainly go on to develop pulmonary hypertension. Would think about, could some of the dyspnea symptoms be related to her comorbid anxiety disorder? I don't think so. I don't usually kind of attribute, shortness of breath to anxiety unless we've done a really thorough workup, but anxiety is another really common comorbid condition in patients with COPD. And then I would also think about kind of anemia as a cause of the dyspnea. And with the confusion and slurred speech, I would also worry about an ingestion here. Hard to tie that to the kind of 2 to 3 month process, but there might not be just one process going on here. There could be multiple things. And so I would certainly want to get some chest imaging and an EKG, some basic labs. And I would also want to get a blood gas, preferably an arterial blood gas, but a venous blood gas as well, to look for hypercarbia given the altered mental status. But I'd say at this point, kind of pretty broad differential, kind of just based on the history, but most worried about kind of primary cardiac and pulmonary processes at this point.
Yeah, no, fantastic. I think one of the things that really stood out to me about what you said is, you're taking this history of, COPD, but you're actually, you're holding that, but you're holding it as a presumed diagnosis. So I think that just really stood out to me as something that you are taking into account in terms of how you're framing your differential, but not taking that as certain, which I thought was really interesting. you touched on this a little bit, but I'm curious how, we have this chief concern of shortness of breath, but in the context of, an altered mental status where I believe her roommate found her confused. And I'm wondering if you could talk a little bit more about how that history of confusion kind of affects how you think about shortness of breath.
I think the most direct, connection I would think about is, is could she be hypercarbic? Certainly, people can become altered from hypoxemia as well, but I would say especially given this kind of slower time course, I would think about hypercarbia. And check for that. I would say it's pretty variable. We can have patients who are quite stably hypercarbic and they have a compensated respiratory acidosis and they don't have any change in their mentation. But if it's a more kind of acute development, then there can be a much bigger impact. And I would also, there may not be a direct connection to her respiratory status, right? We don't have her kind of exam or vitals yet. So there could be something else, going on.
Yeah, no, definitely. Thank you. And you mentioned some of the tests you wanted to get. I'm curious on exam if there are specific things that you would be looking for.
Yeah, so it certainly would want to do a thorough exam here, especially in the absence of being able to get like a really detailed history from the patient. And so, I usually go when I'm sort of doing an exam as a pulmonologist. I often will kind of start where the airway starts, which is in the mouth, have people open the mouth. And so that's super useful. I've seen thrush and it turns out the patient has HIV. You can learn a lot by looking in somebody's mouth. So, depending on how well she's able to cooperate with the exam, kind of start there. I would definitely want to do a thorough cardiac exam, right? Is she regular? Does she have normal heart sounds? Any extra heart sounds? Try and get a sense of her JVP if we can make it out. And then the first thing I looked at, for the lung exam itself is just sort of what's the overall work of breathing here. And so, maybe she's breathing 8 times a minute, and then I'm going to be thinking about, an ingestion, opioid ingestion, for instance, or maybe she's breathing 30 times a minute. And then, if she does have COPD, it can sometimes be tricky. Yes, people can have wheezes, but sometimes they'll just have really poor air movement. Right. And you won't hear much wheezing. And you can sometimes hear crackles. If she's really been kind of confused and altered for a while and not breathing well, she could have some atelectasis. So I think there's a range of kind of things I'd be listening for, but we'll try and listen, kind of over as much of the chest as I can. And then I would be, mostly kind of honing in on the cardiac and pulmonary exams, and then kind of her mentation to find out, how severely altered is she. And then of course, looking at extremities. And I also always pay close attention to the hands as part of my exam.
Fantastic. All right, so we know what we're looking for. Brian, feel free to give us more information.
Great. So just kind of jumping into some more objective information that can help us out here. So we typically start with vitals. And so as this patient kind of rolled in, and we're getting report from the emergency department and emergency medical services who are bringing the patient in, and they reported that she had an initial blood oxygen saturation of 40% and quickly put her on some oxygen. So our initial vitals that we have are, she is afebrile at 36.7 degrees Celsius. Her heart rate is 82. Her blood pressure is 87/59. Her respiratory rate is 22, and her oxygen saturation is 77%. And that's on 7 liters flow of non-rebreather. And then picking up on an exam. So when you initially see her, and the first thing you notice is that she's ill-appearing. She looks cyanotic and dusky, particularly around the lips. She's drowsy and inattentive. She also has a very thin body habitus. As I mentioned, for a head and neck exam, her lips and face are cyanotic, but her mucous membranes are moist. She doesn't have any oropharyngeal erythema or exudates or thrush. Her cardiovascular exam, she's regular rate and rhythm. She does have a 2 out of 6 systolic murmur at the left sternal border. She has marked JVD that is above the angle of the mandule when she is sitting upright. Her pulmonary exam, she has diffusely diminished breath sounds, bibasilar crackles, but no wheezes or bronchi or audible. She has a benign abdominal exam. She's soft, non-tender, non-distended. And then for her neuro exam, she's drowsy and slurring her speech. When you are able to engage her, she's oriented. She understands kind of who she is, where she's at, kind of the situation that's going on and why she's in the hospital. But non-focal, otherwise non-focal neuro exam. So no focal weakness or sensory loss in any of her extremities. Her extremities are warm, well perfused. She has moderate to severe pitting edema in her bilateral lower extremities. Her pulses are intact, and you notice that her capillary refill is 5 seconds. And I will stop there.
All right. So again, yeah, go, just dive in.
Yeah. Well, Lee certainly is quite ill. So, I mean, the main things that jump out, at me are, first of all, just, on her vital signs, her hypotension and her pretty profound hypoxemia. One point I'll make about that initial pulse oximetry showing 40% is that probably anything below the mid 70s on a pulse oximeter, we just don't know what it is. And that gets back to how the pulse oximeter was developed, which was with a bunch of healthy volunteers kind of breathing hypoxemic gas. So, it's striking, but who knows how to compare any oxygen saturations below kind of about the 70s. And we know the pulse oximeter, there's more and more data accumulating that it is also much less reliable for patients who have darker skin tones. So it does seem, based on, cyanosis, everything else, this lady, truly is profoundly hypoxemic, but I would still kind of want to get additional data with the arterial blood gas to look for hypercarbia. I am definitely kind of the other things jumping out at me from her exam are really making me more concerned about a cardiac, etiology for her presentation between the distended neck veins, the kind of delayed capillary refill, and the murmur. Kind of hard to know what to make of the bibasilar crackles. Could that be some pulmonary edema? Could it be something else? I think still want some imaging, but definitely kind of more concerned about kind of a cardiac etiology for her dyspnea and hypotension. And I would kind of especially think about things that are going to, present with this kind of with the elevated neck vein. So yes, it could be pulmonary hypertension, but cardiac tamponade would be another thing that I would consider. It doesn't, less concerned about a tension pneumothorax, given your exam, but those would be the things that I would think about, either kind of, a profound, pump failure. Maybe she's had a right-sided infarct, or more likely with the neck veins that elevated, pulmonary hypertension with more of a chronic kind of volume overload. But I would want to do, in addition to kind of EKG and chest imaging, I would probably want to grab an ultrasound machine if we have one handy and take a look just quickly at the heart, looking at, and so sort of a point of care ultrasound, just a basic, I really use it as a screening test. So I'm decent at ultrasound, but I'm not good enough to, do kind of advanced maneuvers to really look at the valves, et cetera. So when I use it in a patient like this who's has respiratory failure and is really hypotensive, I'm going to be looking for, okay, do they have a pericardial effusion? Yes or no? Roughly, kind of how is their LV function? Good, not so good, or can't tell. I'm going to look at the IVC to kind of augment my physical exam, to look at volume status. And then I'm going to kind of roughly compare chamber sizes. So how does the RV compare to the LV? So I would want to kind of add an ultrasound to the to the test. And I would probably, I would even maybe get that before a chest radiograph and an EKG, depending on kind of what you have available at the time. But I think it can be really helpful to augment your exam.
Yeah, that was, I think you just gave so many learning points about kind of how to walk through this exam. And it was really fantastic how you walked through that and kind of narrowed in on the main pathology you're suspecting in the heart and then potentially the lungs. I'm curious, you mentioned the profound hypoxemia in the setting, even with 7 liters of on non-rebreather. I'm curious just how that profound hypoxemia affects your differential here. I know you mentioned kind of the limitations of the pulse oximeter, but how do you just think of that? How do you use that profound hypoxemia to affect your differential?
Yeah, so one of the things, so I kind of think of, I put hypoxemia into 5 buckets, right? So 5 causes of hypoxemia. So, we're Portland, right? So we're not at high altitude, so we can cross that off the list. Hypoventilation, we don't know about that yet because we don't have a blood gas yet. So no way to assess kind of for hypoventilation without a blood gas. And then, diffusion limitation is generally not going to be a cause of kind of clinically significant hypoxemia by itself. So usually kind of set that aside. It can be contributory. And then the big 2 that, you're going to see in the inpatient setting are generally going to be either low VQ or shunt. So one of the, probably the, fastest way to distinguish between those 2 is going to be how easily does the hypoxemia correct with supplemental oxygen. And so low VQ tends to correct very well with low flow oxygen, and shunt corrects less well. So I think the sort of first-year medical student explanation of shunt is, shunt doesn't correct with supplemental oxygen. But like many things in medicine, it's actually more complicated than that. And it depends on how, what is the shunt fraction? So how bad is the shunt? So here it's a little bit tough to say because again, like, who knows what that initial sat really was, but I'm thinking like, maybe, could there be some shunt given that 7 liters is a pretty decent amount of oxygen. It's still considered low flow, but the sort of classic VQ, low VQ hypoxemia is someone who goes from, like 85 to 99% on 2 or 3 liters. It doesn't take a lot to correct them. And so here I would think about shunt, but that could be an intracardiac shunt, like maybe there's a patent foramen ovale, or it could just be, she has a pneumonia and is still perfusing that part of the lung. I noticed that she's on amlodipine, she's on a vasodilator. So it could be, it doesn't have to be it can be a physiologic shunt, I would say. So I am kind of wondering about that with the how hypoxemic she still is.
Yeah, great. Thank you. Thank you for walking through that. Yeah, go ahead, Brian.
I'm going to say the other thing that kind of stood out to me too is just like with her hypotension and delayed capillary refill. So thinking about somebody whose refill is 5 seconds, and we think of normal being around somewhere between 2 to 3. So in the setting of hypotension, I'm definitely starting to be concerned about, potential of some shock physiology going on as well. And so I think with the, certainly with the neck veins, we see some evidence of volume overload, but I guess, the big question I have too is there a pericardial effusion or a tamponade that's kind of contributing to this picture?
Yeah, Brian, that's a great point. And so anytime I see, someone with hypotension, I always ask, okay, is this just hypotension or is this shock? And so, for shock, I'm looking at, is there evidence of poor organ perfusion? And so kind of with her mental status, that would be, I think that's certainly, a concern. She does not seem to be perfusing her brain well. And that's where, the cap refill comes in again. And then I would kind of, again, some basic labs, liver function, kidney function, et cetera, would be helpful as well.
Great. And then one other question that came through in the chat is, in that last aliquot, you had mentioned the importance of looking at the patient's hands in the exam. And here we see the capillary refill. I was wondering if you could elaborate a bit on what else you look for in the hands in an exam. Is it mainly cap refill or clubbing or something else?
Yeah, so I certainly look for clubbing. In the outpatient clinic, I look, there are a number of, there are some findings besides clubbing that can turn up in the hands, right? So findings of dermatomyositis, rheumatoid arthritis, et cetera. And then I like to look at both the nail beds and kind of the palmar surface of the hands. I've seen, just kind of looking and seeing findings concerning for emboli. And, lo and behold, somebody had endocarditis. And so I would say probably like the hands and the mouth are like are many sources of kind of hidden information that I've found on the physical exam. So in this case, I think I'm most I would probably, again, be looking for, embolic stigmata, cap refill, clubbing, which could point to kind of a chronic underlying pulmonary condition. You should not get clubbing just from COPD. So if I saw that, I would be thinking, okay, there's something else going on here chronically.
Yeah, I was actually wondering if you could elaborate more on, I feel like clubbing has come up a few times and I never know what to do with that. So when you see clubbing, what would that do for you? I know it's not present in this case, but just in general.
Yeah, so in a situation like this where, I'm told that somebody has COPD and not kind of other underlying lung conditions, I would not expect to see clubbing. And so if I did, then I would say, well, maybe this is not clubbing. Maybe it's not COPD that she has. Maybe her shortness of breath is due to a diffuse parenchymal lung disease, bronchiectasis, something else. It would kind of make me want to look deeper. I think less helpful for the acute setting, more for sort of this like 2 to 3 month period.
Got it. That makes sense.
You can see it in malignancy as well.
Similarly, chronic cardiac problems. I know it maybe not so much an adult, but say like congenital lung disease can cause that. So I think there, concerns about our cardiac function too, like the presence of clubbing might make me think of that as well.
Awesome. Thank you both for that explanation. All right, Brian, feel free to give us some more information.
Great. So, with our exam in hand, we talked about a couple of things: EKG, chest X-ray, a point of care bedside ultrasound, just to give us some quick information. So maybe starting with the ultrasound. So we did grab an ultrasound and do a brief scan. The main thing that we noticed was that she did not have a pericardial effusion. There was apparently normal cardiac function, so the systolic squeeze appeared to be normal. And she had interventricular septal flattening. And in addition to our visible JVP that we can see, she had a very plethoric and IVC with little respiratory variation. And then in addition to that, we can give the EKG, and maybe we can slide over to the EKG and I can discuss the findings there. Oh, great. Perfect. So the main takeaways from her EKG, if you just want a minute to look it over, and we'll certainly review it, but the main findings are that she's in sinus rhythm, and her axis is right axis deviated. She has probable left atrial enlargement, just based on the morphology of the P waves, relatively low voltage. And the kind of read from the cardiologist is to consider right ventricular hypertrophy and possible old anteroseptal infarct. And Dr. Brady, did you have any other comments on the EKG, or I can move on to the X-ray as well?
I think the EKG kind of goes along with your point of care ultrasound findings and in your exam. So certainly, if you had gotten the EKG first, then would have certainly been honing in on the right ventricle and on your point of care ultrasound. But I think it goes along.
And then the chest X-ray we can pull up, and the main findings here are that there is a small layering effusion, pleural effusion on the right side with overlying compressive atelectasis. So there's some sort of opacification involving the right lung base. And there's also some associated ground glass airspace opacity there. The heart border appears, the borders appear to be sharp. The size, there's no kind of striking cardiomegaly. If anything, the right side of the heart maybe looks a little bit prominent, but nothing too striking. I think the major findings here are the potential opacity in the right side and potential pleural effusion. But Dr. Brady, I'm wondering if you have any other pearls on this chest X-ray or any findings.
I think that kind of the layering appearance where, we don't see like a very classic meniscus that we often think about for a pleural effusion, but in a portable film, and especially, it says right on the top, right, she's supine, it often will look more like this kind of gradual kind of white fading into kind of light gray. And so this would certainly, I think that, that's a common finding for a pleural effusion, and then kind of hard to know what's underneath. Is that atelectasis or something else? And, you've got your ultrasound machine, so you can sort of confirm size of the, confirm the finding of effusion and estimate the size. So I'd say this doesn't necessarily narrow our differential very much more at this point. Certainly you can get pleural effusions in both kind of RV and LV failure. You don't typically think of them in pulmonary hypertension, but you certainly can. And so I don't know that, I'm not sure the film kind of gets us any closer to what's going on compared to the other data we have.
I think there was I was just going to say there was a great point in the chat about the use of ultrasound and looking at pleural effusions. I think that's a great point. And we did throw the ultrasound on this, and there was a pretty apparent effusion. And in addition to the effusion, I think one thing that, always on the differential for shortness of breath is a pneumothorax. In addition to chest X-ray, ultrasound is another great modality for discerning that.
Yes, definitely. I love all the highlighting the value and utility of ultrasound, especially in this case. Dr. Brady, I'd be curious to know, with all of this information here, I'm curious, how are you framing this case in your mind? What is kind of the dominant issue, and how are you framing it?
Yeah, so I think I would kind of putting everything together. So you have a woman in her 60s with a long smoking history and a chart diagnosis of COPD, coming in with sort of acute on subacute dyspnea, now found to be have profound hypoxemia, hypotension, and several signs of kind of RV strain, including kind of on EKG and POCUS. And so I would really be thinking about, does this patient have RV failure, whether it's just acute or more likely acute on chronic, kind of given the timing. What that's from, I don't know yet, but that's kind of what this is looking like a little bit to me. And that's the big thing I would worry about in this case, because that can certainly be challenging to manage.
And what would your next steps be in evaluating this patient?
So I think, at this point, I think we have a lot of data. I think probably I would take a sort of a pause in our evaluation and move a little bit into management phase. And so, she's very hypotensive. We'll kind of, I'm assuming our labs are going to trickle back in soon, but I'm already worried enough kind of with her poor mentation that I think she probably needs some kind of resuscitation while we wait for the rest of the data to come back. So, worried about RV failure. So hypoxemia is a pulmonary vasoconstrictor. So I would want to support her oxygenation more. And I think, the quick thing, of course, is just to turn up the oxygen flow on the mask you already have on. I wouldn't be surprised if she needs more. So if high flow oxygen, so sort of 20, 30, 40 liters, if that's something that, like we have that readily available here in Portland, if that's readily available, where I would think about that in this setting. And then I would think about starting a vasopressor to support her systolic blood pressure. And the reason I say that kind of a pressor and not an inotrope is that in kind of an RV failure, the RV is perfused both in systole and diastole. It's sort of continuously perfused, and the perfusion really depends on the difference or the gradient between your systemic pressure and your RV filling pressure. And so in someone like this, right, whose JVP is, at the angle of the mandible sitting up, we know that RV filling pressure is going to be really, really high. And so I think we probably need to decongest her and get some volume down, because I'm worried her RV is kind of fallen off the Starling curve. But at the same time, I want to raise that systemic blood pressure to kind of perfuse not just her RV, but her other vital organs. So I would kind of think about doing those things to support her while we probably get formal echocardiogram. I would think about imaging for a deep venous, venous thromboembolism, whether that's going to be start with lower extremity Dopplers, depending on how stable she is to travel, or CT pulmonary angiogram.
All right, Brian, what happened next in the case?
So I can give you some additional information. So those labs are starting to trickle in, and in the meantime, she was placed on BiPAP for oxygen support. One of the first things we got back was a arterial blood gas. So I can give you those results. The pH was 7.23. PO2 was 92, or sorry, the PCO2 was 92, and the PO2 was 68. She had an arterial oxygen saturation of 86.4%. And that's on BiPAP settings of 22 centimeters water over a EPAP of 8 centimeters of water, and an FiO2 of 60%. In addition to that, a little bit of time later, time goes by, and we start getting our chemistry back and our blood counts. So the notable thing on her blood count, she has a white blood cell count of 7.6. Her hemoglobin is 12.6, and her platelets are 256. Her chemistry is notable for a sodium of 127, a potassium of 5.5, a chloride of 91. Her bicarb is 32. her BUN 54, and creatinine of 1.98. She has a glucose of 113. Her LFTs, her AST is elevated at 336. Her ALT is 281. She has a normal alk phos at 41. Her T-Billy is 0.5, and she has an albumin of 2.5. In addition to the blood gas, we also sent a lactate with that, which was mildly elevated at 2.4. She had a troponin that was also ordered and was normal, so less than 0.02. She had an NT-proBNP, which was elevated at 3,381. And going back to some of the, the concerns about potentially an ingestion or her encephalopathy and what might be contributing to that, we also sent a UDS, or urine drug screen, which was negative, and then ethanol level was also negative. And she also had negative Tylenol and salicylate levels.
So a lot of information here, but Dr. Brady, what's standing out to you in these labs?
So I think, these are I think probably some of the other signs of poor end organ perfusion that go along with her fermentation. So I don't know, if we don't have prior labs, we may not know, is that elevated creatinine acute or chronic, but sort of looking at the rest of her panel, I would, worry, I would presume that that's acute. And the elevated transaminases as well, I would worry about hepatic congestion, kind of with that kind of the elevated right-sided filling pressures we're seeing on exam. The other thing I'll say about her blood gas is, and it's hard to know, right, is the hypercarbia the cause of her confusion, or is it kind of her shock? I would probably favor the shock, but it's tough to say. Hypercarbia is also a pulmonary vasoconstrictor, so I would also want to kind of work on correcting that. And sometimes high flow nasal cannula can do that. Bi-level would be another option. It's not my favorite option for a patient in shock, particularly someone who's altered, but if you're going to use it, then I think a short time limited trial is always the safest way.
Yeah, it's very cool to see how you took all these kind of abnormal labs and really simplified it down to, this could be a result of poor perfusion given, signs of shock, and then also hypercarbia potentially contributing to her altered mental status. From here, how would you address management and next steps?
Yeah, so I think, so next steps, other things that I didn't really mention initially, but I think, kind of taking a step back. So kind of really thinking about kind of the right heart and RV failure here. Could there be something else going on? Is there a pneumonia, behind that pleural effusion? And this is really septic shock and someone who just happens to have underlying pulmonary hypertension. It certainly could be, the white count's is not elevated, but, I would maybe add on a differential. Is it, does she have bandemia, despite that white count being low? You could think about some empiric antibiotics, but overall, I still think this fits best with RV failure. So I would choose a vasopressor. I think norepinephrine would be a good choice here, kind of mostly going to be a systemic vasoconstrictor with just a little bit of beta adrenergy. And I would kind of work on getting her blood pressure up. And, what is the right blood pressure? I think all blood pressure goals in critical illness are really pretty arbitrary. You have to see if they work for the patient. And so if, you get her mean arterial pressure up to a certain amount and she wakes up and she starts making urine, then that's probably a good pressure for her. But I would, start with that. And then I would start with some diuresis. And it's nice to be, I think it's really nice to be gentle in a patient like this. most of the time, when someone is in RV failure, particularly if they have any component of chronic right ventricular dysfunction, they have too much preload and you need to diurese, but I like going slowly. And so you could think about a loop diuretic infusion, or kind of starting with a low dose and then increasing from there. And those would probably be kind of my mainstays of treatment. I saw someone mention thoracentesis. I think that's a great point. You certainly could do that. At least a diagnostic thora to make sure, because I certainly could be wrong here. This could be, a pneumonia and septic shock, and it would be helpful to get those fluid studies to see if the fluid, it looks just more transudative, kind of from heart failure, or exudative.
All right, fantastic discussion. Brian, what else do you have for us in this case?
So so we started her on norepinephrine and had kind of increasing requirements, and pretty shortly thereafter was also started on epinephrine. In addition to that, started to slowly diurese her with small bolus doses of IV Lasix, and eventually did go with the drip strategy to promote diuresis. After that, she was stable enough to go for a CT angio chest, which we can maybe pull up. And the main findings from the CT are that we did find few pulmonary emboli within the subsegmental right upper lobe and right lower lobe, as well as the left lower lobe pulmonary arteries. So these are subsegmental PEs, and there's evidence of associated right heart strain with mild cardiomegaly, enlargement of the right atrium and right ventricle, and flattening of the interventricular septum. The CT also picked up the right-sided pleural effusion with what was called by the radiology team as a compressive atelectasis.
Wow.
So these are just examples, just showing you the left pane being kind of a somewhat enlarged appearing pulmonary artery, and the effusion there on the right. In the left pane, can see pretty clearly the size of the RV is pretty large compared to the LV. And typically for the LV, you'll see a nice round kind of muscular shaped ventricle, and here it is looking pretty flat, so telling us that there's a fair amount of RV pressure overload. Anything else, Dr. Brady, to comment on the CT?
Yeah, I mean, I think that probably the natural question that comes up is, okay, if there are pulmonary emboli, is this all a massive PE? I think hearing that they're kind of segmental, subsegmental, I don't think they're helping her, but I don't think I would blame this entire presentation on pulmonary emboli. I think the kind of the extent of her RV failure seems out of proportion to those emboli, and so I would probably anticoagulate, but I would not go for thrombolysis or something like that in this case.
Great. And so, yeah, afterwards, with those emboli, we put her on a heparin drip for therapeutic anticoagulation. And while back in the unit, the echocardiographer came around and did perform a formal transthoracic echo. And the results of that, the main findings were that the RV global systolic function was determined to be mildly reduced. And there was a estimated right ventricular systolic pressure, or VSP, of 74.3 millimeters of mercury.
And then Brian, just for the sake of time, were there any other last details of the case? Last pieces of data at all?
That's all of the data. I did see somebody ask about pulmonary nodules or masses on the CT. There was a small sub 4 millimeter nodule that was thought to be kind of an incidental or not particularly contributing, but there was evidence of one.
Great. And yeah, Dr. Brady, I'm curious to hear your reflections on this. And what really stood out to me is, your last comment about, stating that these PEs, of course, were not helping the patient's condition, but do they fully explain the extent of right ventricular dysfunction? I'm curious what your thoughts are on that now, and if that's changed at all.
Yeah, I think I still would think that it's unlikely that they're the kind of the only thing going on, especially with that, again, like kind of going back to her history of like 2 to 3 months. I would wonder if, she was kind of becoming volume overloaded, right? Kind of had some edema. She got a loop diuretic. Was it the right dose? And then maybe the PEs, could have been sort of what tipped her over in the last week and made her really sick. But it doesn't seem like kind of these small PEs really explain sort of everything going on over the last 3 months. So I would guess there's probably a combination of a few things. She may well have some underlying pulmonary hypertension from, maybe from longstanding COPD. Again, I wouldn't assume that. I think, hopefully once she's sort of diuresed and recovered, we can have her, follow up in clinic and kind of get a thorough workup to kind of repeat the echo and kind of work her up for pulmonary hypertension. And I would add that, she would need a right heart catheterization to prove pulmonary hypertension before, at some point along the way, but I would not rush to do it right now. Yeah, and that's a good point. A good point. If there's kind of RV hypertrophy, then that would definitely be a sign that some part of this has been chronic, because that's not going to happen acutely. The RV can dilate, but it's not going to hypertrophy immediately.
And Brian, any reflections on this case, and any comments to Dr. Brady's last reflections here?
Yeah, I mean, I think I can just share a brief kind of case resolution and what happened. So, started on the pressors for blood pressure support. She was started on the diuretics, and then also we mentioned the BiPAP for oxygen support. And she actually pretty improved quite rapidly over the course of 12 or 24 hours with diuresis, an improvement in her hypoxemia. Her hypotension improved. She came off pressors pretty quickly. At one point before that, she was transitioned over vasopressin to kind of spare her pulmonary circulation, just given this concern for right-sided pressure overload. So she did actually quite well and improved. And just kind of glancing at some follow-up data, it seems like she's doing pretty well. Was connected with pulmonary as an outpatient, and had actually quit smoking, and seemed to be doing quite well. So I think ultimately we thought the final diagnosis was cor pulmonale, and so acute right ventricular overload or right heart failure in the setting of her hypoxemia, likely from chronic lung disease. She did also finish a empiric course of antibiotics for pneumonia.
Wow, Brian, I thank you so much for putting this case together and kind of all of the learning points. I can't imagine how much work went into making such a cohesive case. So I really appreciate you bringing this for us. And Dr. Brady, just phenomenal discussion. Any last thoughts before we dive into Deborah's teaching points?
No, I don't think so.
Awesome. Well, again, I really appreciate you. Oh, Brian, were you going to say something?
Yeah, I just did want to comment. There's a question about a malignancy workup. She did kind of was scheduled for a follow-up CT scan to kind of track this nodule that was found, but I don't think she got any additional larger malignancy workup than that. Yeah.
All right. Well, thank you both so much. I know I've learned a tremendous amount from your discussion, Dr. Brady, and I will pass the mic to Deborah to summarize the teaching points.
Hi, everyone. Thank you for the case. And Brian, thank you for the case, Dr. Brady. It was really interesting. And going for the teaching point, and this patient presented with shortness of breath. So we thought first that it was related of the COPD, of could be other causes like hypertension, pulmonary hypertension, arrhythmia, or could be an anemia, or the anxiety. And then looking for the exam in this case, we learned to start with the mouth, look for the cardiac exam, for the pulmonary, looking for the hands, looking for the clumping dermatomyositis, rheumatoid arthritis, looking for the extremities, and focusing in the pulmonary and the cardiac exam. The cardiac, looking for the heart sound, extra heart sound, the GDP, the pulmonary for the rhythm, the respiratory rate, the wheezes, the crackles, the atelectasis. And in this case, the cardiac exam, the patient presented with descending neck vein and murmurs, and possible causes could be a pulmonary hypertension, cardiac tamponade, pulmonary edema, right side infarction. So we have to look for an EKG and for a focus. And approaching the hypoxemia, we have like 4 causes: high altitude, hypoventilation, low VQ, and shunt. And looking in this case for the clumping, possible causes could be the bronchiectasis, like chronic cardiac problems, like interstitial lung disease. And we had like a great pearl that sometimes the focus could be better than a supine portable chest X-ray for many-thoracic pathology, especially for like a pleural effusion. And in this case, the pleural infusion could be for the right and the left heart failure and a pulmonary hypertension. So yeah, thank you so much, and I hope to see you all tomorrow.
Thanks for having us.
Yeah, thank you, Dr. Brady. Thank you so much, Brian, and thank you everyone for tuning in. Awesome teaching points, Deborah.
Thank you.
We'll see you all next time.